Good afternoon. Thank you for joining us. This is Catherine Lee with the Green and Healthy Homes Initiative. I just wanted to welcome you to today's webinar on financing multifamily affordable housing retrofitting, updates on healthcare sector resources. We're going to get started in just a minute, and I will let you know when we're ready to go through our presentation. Just wanted to share a couple things with the attendees today. You are all in listen-only mode for this presentation. If you have questions or comments, you can submit them on your dashboard. There's a question section, and you're welcome to put in any questions for the presenters or comments that you want to share with the rest of the audience. We'll be happy to share those at the end of the session. And we are recording today's session, so we will be able to share the recording of the webinar as well as the slides. So the links and other things that you will see during the session, we'll share with all the attendees by email afterwards. There are some handouts that we've included that you can download that you'll see in the handouts panel of the GoToWebinar sidebar there that we'll refer to in the session. Will be emailed as well in case you have any issues with downloading them. If you have any technical issues today, you can email me at clee@ghhi.org, and I'll try to help you out as we get through the session. So we'll just wait one more minute for people to join, and then we'll get started with the presentation. Thank you. Okay, and it looks like we have a good number of attendees who've registered that have already joined. So we're going to begin with just a little bit of background on why we wanted to share this presentation with the NewHab organization or group. We've had some conversations in the past about healthcare financing for energy retrofitting in multifamily affordable buildings, and wanted to update some of those resources and wanted to make sure that those were available to NewHab participants prior to the NewHab convening in Detroit at the end of May. So this is really an update on past presentations and an opportunity to have these conversations as a way to facilitate some of our interaction next month in Detroit. So we have an agenda that includes information on healthcare payer resources that can be utilized for multifamily housing repairs and retrofitting and some other complementary services that we'll talk about. We've got a section on it that's a toolbox for healthcare funding, as well as some case study examples from IFA states and other partners that GHHI works with, so we can talk about some specific examples of how those funds are applied to energy retrofitting and other multifamily healthy homes interventions. And then we've got some resources to prepare for local engagement on these topics and time for questions and answers at the conclusion of the presentation. So just to begin with, we want to give you some background on GHHI's work in this space of identifying and using healthcare funds for housing retrofits. And for our organization, this really is grounded in the work that we've done in development of the GHHI model for housing interventions that we utilize in our sites across the country. So what we mean by those terms, to walk through it, is that GHHI sites align, braid, and coordinate housing repair programs, which are typically focused on single home health hazards or energy inefficiencies, to pull together those resources to the greatest extent possible. Care is coordinated for families that are experiencing home health hazards and housing cost burdens because of inefficiency. So there is a creation of a single intake process for families, coordinated assessments and services among agencies that are performing that work, data sharing and analysis that's done in a more comprehensive and efficient manner. And that way we're able to address all of the home health hazards and efficiencies rather than moving forward with an in-service system that only provides standalone services. So this is something that's been adopted in over 30 sites across the country. So in addition to that GHHI site work, we also are engaged in state-level strategic plans that try to braid together housing, energy, and economic development planning, and some other healthcare financing work that we'll talk about, particularly in Pay for Success during today's presentation. So this hands-on work that we're doing with community partners has really been a resource that we have used to inform research that we're doing and have been doing since 2009, 2010 into the connectivity of issues of environmental health hazards within housing and in energy and efficiency in residential buildings. So we've got just a list here of our past publications that we wanted to highlight, some of the previous work that we've done in this space of looking at the relationships between energy efficiency and home health, and particularly lead hazard control and asthma trigger control, and structural issues that can lead to home injuries and accidents that cause trip and fall injuries in particular. So wanted to just share this with you so you get a sense of the work that we've done that has led to our most recent publication, which came out earlier this year, that's called Achieving Health Equity Through Housing, Understanding Non-Energy Benefits in the United States. So just wanted to highlight that here for the audience in case you have not seen any of our communications about that up until this point, to let you know that this paper is available for download on our website. And we are planning to share some updates and announcements of conferences we'll be attending, where we'll be presenting information on this paper. This, we hope, will be a resource for a lot of people in the New Hab network because of its on non-energy benefits, findings on individual level non-energy benefits, as well as community and sectoral level impacts, and the recommendations that we make for program administration and financing, which we'll dig into in this presentation, but the paper will give you some context to where some of those recommendations are coming from in a little more detail as well. And in addition to our site work and our research, we also provide services to program partners around the country to look at healthcare financing. So these are just some examples of the work that we've done in research and development of models for social impact finance, or Pay for Success, and some of the work that we've done to measure the benefits in terms of healthcare savings of housing interventions. So I'll ask my colleagues to talk a little bit more about some of those projects in their presentations. We've got with us today Brendan Brown from our team, as well as Will Klein. So they will present some of these examples in greater detail. So considerations and policy goals. Just want to highlight a couple of things before we get into the slides on the toolbox. We will be covering several different models of healthcare payers in the models that are existing for healthcare financing entities, from models to managed care agencies to state Medicare and Medicaid offices, and the ways in which housing developers and property managers can access funds to provide resources for home modifications for specific health outcomes that also are related to energy efficiency retrofitting. But there are just a few considerations that we want to highlight before we get into that. Some being that the evidence base for healthy home services is really key. So we're going to talk a lot about data collection and analysis needs. That is a component that's really necessary for a lot of healthcare financing resources. Also that housing professionals and people who are credentialed are really also a necessary component in a lot of state models for utilization of healthcare services. So we'll provide some examples, but also have some additional resources for thinking about how to get frontline health and housing assessors and other people providing professional services credentialed so they can access funds in this space. There are some other things that we want to talk about, including hospitals utilizing community benefits to keep people healthier rather than paying for uncompensated care, which is traditionally how hospitals have used their community benefits resources, which we'll talk about in detail. And again, just the increased use of data around impact measurement for healthy homes interventions. And thinking about capacity needs for data collection, management, and analysis is really critical to today's discussion. Engagement, as we prepare to get into our toolkit, is that state Medicaid programs and other healthcare payers and providers are looking at the triple aim model, which you see a diagram up to your right, that there is a triple impact on population health, per capita cost for healthcare services, and experience of care. The different programs have various flexibilities and authority for how they can implement their programs and what kind of services they can reimburse for. So there are effective strategies, but the types of strategies will vary pretty widely by state. So we're going to give a lot of examples today of state-level programs that use Medicaid and value-based purchasing and other forms of payments, but rules vary pretty widely from state to state, and everyone participating today will do what we can to try to make sure that you have the resources you need to be able to access information on your particular state that you're working in to see what is possible in terms of the kind of funding you can use. Third, that we need champion build relationships in any kind of development of healthcare payer models, or person or entity that is willing to listen to housing developers' ideas on how to apply healthcare finance to the work that you're doing. In some circumstances, that's a Medicaid office. Sometimes that's an insurance agency or particular office or a public health entity. But finding those right people who are interested in hearing about non-energy benefits, the impact of health impacts of energy efficiency or retrofitting, and all of those things. So we're going to help as much as we can with messaging on that so you can identify the right champion in the communities you're working in. Again, credentials are important, so we'll talk about those workforce analysis needs and understand and align incentives so people have an understanding of what they'll get out of the partnership you're looking to develop. So one other paper or publication that we want to make sure that we share with you, which I didn't include in a handout, but I'll make sure that it's in the email, is the Sustainable Funding and Business Case publication that we put out for GHHI home interventions for asthma patients. The population health work that we do around asthma will be heavily featured today, but there are other healthcare that will or public health issues that we'll focus on as we get into our examples. And just one other thing to keep in mind, that when we prepare information about healthcare partnerships, we typically will want to present information about how to target high utilizers of public health resources, which is why there are pretty clear models out there for asthma, but there are other large public health issues that can be impacted with housing modifications in energy efficiency and health interventions. So just keeping in mind that we are talking about super utilizers, and that 5% of our healthcare patients using public health resources cover more than 50% of healthcare costs. And in order to effectively drive down those costs, we need to find solutions, community-based solutions, including housing, to make those reductions. And with that, I'm going to pass it to Brendan Brown.
Okay, and thank you, Catherine. Everyone should be able to hear me now. I'm unmuted. And what I have here is our funding toolbox, and really these are just the different pathways that we've identified to reimburse for housing intervention services from CMS and in the health plans or the managed care organizations or accountable care entities that may be the payers in certain states. And so, like Catherine had said previously, not every state will all of these pathways exist, but in certain states you have different pathways that would lead to reimbursement. And so we're going to explore a little bit of each one of these pathways here presented in the funding toolbox and try to give examples. I'll present through the first five from through the value-added services, and then my colleague Will Klein will present on value-based payments, pay for success, and other non-healthcare funding resources such as education and justice. So next slide. And here is an example of, what's going on after the Affordable Care Act is that there's been some changes in the Medicaid coverage, the rules, particular around who can provide services that are reimbursable. Traditional medical services have always been reimbursable for those certified medical professionals, but what we had in 2014 was a rule change that allowed for the reimbursement of non-clinical professionals to perform, home visit or community-based services, and still be able to or be allowed to be reimbursed by Medicaid in states. And so this part of the kind of move towards community-based services had opened up the possibility for who is actually delivering the services, but there's still always the problem of making sure that there is a payment structure or payment mechanism, we sometimes refer to it as, to reimburse these non-clinical or non-traditional professionals. And what we're going to look at is a number of ways that these are done, and give some examples. So we can go to the next slide. Actually, yeah, I'll point. I meant to point out, if we go back real quick, that there's a really good resource too by the American Lung Association. We have the link down below, and this would tell you what asthma, and this is around asthma specifically, but what services are covered by health plans in Medicaid in each state. So how we had said each state's different. This is just one tool to know what already is an existing payment mechanism in your state. And now we can go to the next slide. And one of the immediate changes were because of the rule change was that certain states have gone ahead and moved forward to make these certain home intervention services covered benefits. And so one good example is that case study in Missouri that they actually passed what we call enabling legislation to allow for the reimbursement of by non-traditional providers for asthma services. And so this includes asthma education and environmental assessment. And what they had done is basically specified in the legislation, the amount that they can be reimbursed, as well as the time limit spent doing the activity. And another important feature is that I will say for the environmental assessors, in this case, they also in the legislation define what the certifications were. So to be able to get reimbursed for these environmental assessments, you had to have either Healthy Homes Training certification, which is a well-known program, or the Building Performance Institute has a new Healthy Homes Evaluator micro-credential, which is also specified as a credential. So this kind of goes back to the point of making sure that you can define your public health workforce and then also get reimbursed. It's a good example. It's I know it's being used in Kansas or Kansas City, but it does um, bring a lot of dollars to the state in form of the state had to chip in a certain percentage, which was around $500,000, and then it brought in federal dollars of 4.7 million. And so we hope this kind of example can be repeated in other states. Uh, California was trying something similar last year, and it passed the Senate and the House Assembly, but was vetoed by the governor. That's kind of bad news, but good news is the governor said that he thought that these services could already be reimbursed through other means, such as value-based purchasing, and which we'll talk about later. So next slide. And so as another kind of route is and this is especially in the Affordable Care Act in those few years, there's a lot of different Medicaid waivers being passed to pay for different services. And I will say that we'll give an example of the Section 1915s, which is basically or either the Bs are for mandatory enrollment for anyone in managed care, whereas the 19Cs are usually around long-term support services. And a lot of states will have these waivers, and specifically allowing for assessments, resident education, and home modifications for independent living. Think of like aging in place programs or those type of long-term support services for those more elderly populations or even disabled populations in states. So that's kind of a pretty established reimbursement route. Has limits of applying it to other types of interventions. And we will also look at 1945s are more around the coordination of chronic care. Chronic care, we don't have a specific example here, but there are examples of that around the country. But another more kind of common is the 1115 demonstration, and we'll go through a specific example of that. So next slide. There's several. 1115 demonstrations. The purpose of these were generally to pilot or demonstrate projects in order to scale up or expand eligibility of already existing programs, or where there was evidence base. A lot of this was about kind of having innovative delivery systems to expand the services to the full populations within states. These are generally approved for 5 years, and they typically must be budget neutral. A lot of states have used these. I'll say what we have on the right-hand side here are just examples of those states that had a specific type of 1115 demonstration waiver, which was called DSRIP, or Delivery System Reform Incentive Payment Programs. And these were generally ways that states were trying to get more of extend the clinical care into the community-based side by making partnerships, and these have proved successful. A lot of these states have reapplied and extended their 1115 waivers, DSRIP and otherwise. And so we'll go to the next slide. And so an example of a 1915B waiver is a good example of nurse-family partnerships. This was one was the South Carolina Department of Health and Human Services was allowed to waive provisions of the Social Security Act to make these type of nurse-family partnerships part of managed care, basically a mandatory benefit. And essentially these were home visiting programs that the South Carolina Department of Health and Human Services were able to provide money up front to have these nurse-family partnership services provided to over 3,200 clients. And these, if there was savings generated from those kind of hybrid model, they would be able to pay back into a fund that would allow the services to continue over an extended period of time. So it's a little bit of a hybrid model, and we'll explain more about what pay for success projects are. But this was a unique example of a well-established program, the Nurse Family Partnership, that operates in multiple states, but that where the state of South Carolina felt there was enough evidence in that they were willing to make this kind of a payment arrangement. So, next slide. And another good example of the 1115 waiver, is that, and this is with Multnomah County out in Oregon, but Oregon had passed a waiver originally, and they have just had a new 1115 waiver extended, so it actually goes through June 30th, 2022. But within that 1115 waiver, there's language specifically allowing for HUD Healthy Homes type programs, or Healthy Homes types programs for asthma and targeted, what they call targeted case management, to occur and to be reimbursed as a per visit site, or per visit of a significant $330. And even with the new coordinating care organizations, which basically are similar to kind of accountable care entities, but they cover a specific region, assigned region. There's a lot of motivation to essentially continue these or replicate these practices that have gone in Multnomah County as part of our EPA grant. We're working with Lynn County and the Consortium for Services group there to explore how we can get them reimbursed for delivering these services in more rural counties. So next slide is I think the kind of the third route that is very interesting and has great promise is also the as part of the Affordable Care Act, there are some IRS rules changes, which has allowed for hospital community benefit investments to go to more towards actually getting out into community, whereas traditionally they had been used to fund uncompensated care as part of the hospital system's financing. And with these rule changes, they've the hospitals and hospital systems are required to conduct a community health needs assessment every 3 years, and then and basically adopt that implementation plan to provide more community services. Basically, in these, which is of note to this group, is that there's in these community benefit investments, there is the possibility to use them for physical improvements in housing, and as well as for environmental improvements. There's a good example below of St. Joseph Hospital System using affordable housing, using their community benefits to invest in affordable housing, which they use as supportive housing for both elderly and those homeless patients with HIV, AIDS, as a way to also, help lower cost and to improve better quality of care for those same clients who had needs that exist beyond the normal kind of clinical care can be provided. We've also worked with our Robert Wood Johnson Pay for Success cohort with Presence Health and Elevate Energy in Chicago, and they're currently using community benefits to fund a pilot or part of a pilot, and that's proven to be another, I guess, is another example of using community benefits, and that's a asthma home visiting program where we're trying to blend health and energy dollars. So next slide. And then Medicaid administrative claiming. This is just another I guess kind of a fancy way for saying this is putting the expense under the limited um, administrative expenses that managed care organizations usually have. It's usually has to be less than 15%. But for certain programs, for pilot and other and even for other programs, for full programs, this has been used. The example we have here is the Texas Childhood Lead Poisoning Prevention Program, which began receiving reimbursements back in 2011. Essentially, for the environmental lead investigations, or have a kind of set rate similar to the example we gave before. In Missouri, the difference being the Medicaid office is reimbursing the health plans. In this one, the health plans are taking it out of their administrative expenses and paying for it. So this is something that we've also seen used to fund pilots when you're trying to implement something innovative. But it's as far as scaling up with using administrative claiming, there's some downside limitations because there's a limited amount that managed care organizations would be willing to invest of their own administrative expenses in programs. And so we'll go to the next example. Okay, and so here's the next case study is also just from the Asthma Network of West Michigan. This is not directly administrative cleaning. It's just kind of more of an example of a hybrid kind of where they've had an asthma home visiting program for a long time. It's nurse run, so certain visits within the clinic, if they were meeting at a clinic, can be billed, but then the home visit parts were not being covered. So the service provider in this case was able to negotiate with other partners involved with the managed care organization, which was Priority Health in this case, to cover certain amounts of the cost of the home visit. So kind of a part the Medicaid, the health plan was being reimbursed for certain components that were reimbursable in Michigan, but then other parts they were just paying for, and then another part I would say was being covered by non-healthcare funds. So that's part of the reason why this group is also exploring pay for success is to try to pay for all of those services up front, and then to have them reimbursed based on outcomes, which we'll explain a little bit more about in a second. And then we'll go to the next slide. And so, and this is before I hand it over to Will to talk about value-based purchasing and pay for success. What you can find in a lot of states is that they'll have what they call value-added services, and these are already state-approved services that managed care organizations can provide to their members. So they're what they call covered benefits, and generally they are kind of specific, either supplies or interventions that are specified as a value-added service. So good examples of those are infant car seats, infant mental health, new mothers benefits, portable crib benefits. So we do want to point out that this is a lot different. It's usually a smaller amount and specified, so you couldn't. There's not a lot of flexibility with value-added services. But I think another example of kind of a housing repair, I believe in Oregon, outside of or as part of the waiver they have as a value-added service, is air conditions can be provided to certain people with chronic respiratory problems. So, so that does help for specific problems, but is in a lot of sense it has its own limits, and can be seen kind of for solution for specific problems. And on that note, I think we'll hand it over here to Will Klein to take us through the remaining parts of our funding toolbox here. Will?
Thanks, Brendan, and thanks everyone for joining us. My name is Will Klein. I'm also on the Green Healthy Homes team here. We're going on value-based payments and pay for success financing. So I think the best way to think about value-based payments is another way for the health insurer to pay a service provider such as a community nursing organization or an asthma clinic for the outcomes created from their services rather than directly for their services. And so what this allows is, instead of, as you saw earlier with the Missouri example, where Missouri has said for a home visit, we'll give you 15 or 50 bucks, 75 bucks a visit. Here they're saying, based on the results of those visits as measured by either quality metrics such as the ability of patients to meet asthma scores or reductions in total cost of care, the health insurer will pay the provider based on those outcomes met. And so the text here is a lot about the state policy and the federal policy, and that's because in 2016, there's a new regulation that enabled this sort of value-based payment or made it easier for the managed care organizations, the Medicaid insurance organizations to use it with their provider network. And so I think the other way to think about it is similar in the energy space or the solar space, where you can finance the energy efficiency or solar installation based on the savings generated over time. This is the same sort of thing where you could use this. The provider will get will create cost savings for the insurance company through less hospital visits or asthma or emergency room visits, and they will get paid back for that. And so that leads to the next part of this, which is the next slide, the pay for success financing. And so pay for success financing is largely a product of the philanthropy world that is similarly outcomes based, similar to the value-based contract. And it's a model in which a government agency passes the risk of a new kind of innovative program on to an investor, which is typically an impact investor or a philanthropy who fronts the upfront money, and then as the outcomes are met, whether that's measured in healthcare dollars reduced or other societal goals like reductions in recidivism, school third grade literacy, reduced homelessness, those sorts of things, as those outcomes are met, the government or insurance company would then pay back the investor based on that. And so in the next slide, we can see the traditional pay for success model. And the interesting thing on this model is that there's this intermediary piece that kind of acts as, you have the insurance company down in the right as the payer, and then you have the investor on the left, and they're kind of working with the service provider. But in the traditional model, you have an intermediary that coordinates makes sure that the outcomes are met, that the funds are flowing. And so you have this flow of funds where the investor gives it to the service provider then generates outcomes that satisfy the needs of the payer, and then the payer would repay the investor, and you have this intermediary coordinating all that. What's interesting and what we found in the healthcare space is that this model is really built for government work, where there's restrictions on the government able to hold this sort of contract, and so you need this intermediary. And then the health insurance space, which on the next slide we can start seeing, is that we kind of have broken this model out. And so if you go to the next slide, we kind of broken this into it. So it's this similar set of players. You have the certified Medicaid provider in the middle, which was the service provider at the top of the page on the previous slide. You have the health insurer. And so there's a value-based contract, which we talked about, between the health insurer and the provider. And so that can exist with or without pay for success financing. So if a provider, such as a hospital, has the funds to front the initial upfront costs, and those costs would, in our case, likely include home improvements to reduce asthma risk, could improve stuff around trip and falls, grab bars and sort of things for the elderly, things like that. If they could front the money, they don't need a pay for success funder. The value-based contract allows the health insurer to pay the provider for these services, which are not normally covered under Medicaid, because they achieve an outcome that is covered by Medicaid, which is the reduction of covered services. So the costs associated with delivering covered services, this reduces the cost of that. The pay for success financing comes in, which, if you go to the next slide, is if that provider does not need or does need the additional funds. So this is more like a community health clinic or kind of a smaller community-based organization that is largely grant funded and doesn't have the ability to provide that initial capital to pay for $3,000 to $5,000 of home repairs or multifamily apartment building retrofits, like taking carpets out of units or replacing window air conditioners in apartments, that sort of thing. So that's how the pay for success and value-based work in tandem. And what's a little bit different about the healthcare space relative to other pay for success finances is the ability to kind of break apart these two contracts into two separate distinct things. And so if we go to the next slide, this shows the work Green Healthy Homes is working with cities across the country, about 20 different partners, to try and demonstrate the success of this model. So pretty much covers the gamut of the country with different projects, with health plans, with community-based service providers, with housing agencies, with energy efficiency providers, trying lots of different models to eventually get to the point where we get one of these contracts signed and get the dollars moving. And we're piloting these services in a number of different cities. Next slide. And so this kind of is to summarize the rest, all of our healthcare stuff. This is there's a number of different payment structures in healthcare, and it can kind of get confusing depending on what scale you're talking at. So on that left diagram, the federal government reimburses states roughly half of their money that they spend on Medicaid. They provide additional funds. The state government contracts out the insurance in most states to different insurance companies through either managed care or other structures such as accountable care. And that is managed care is typically what we call a capitated payment model, which means they give the health insurance company a fixed fee for their patients up front for the year, and it's up to the health insurance company to spend less than they were given. And then between the insurance company and the healthcare provider, one thing is between the state and the insurance company, that's where a lot of the waivers that Brendan was discussing earlier kind of fit in, is those are negotiated waivers between the state and the federal government, and they affect the types of contracts that they can have at the insurance company level and also the healthcare provider level. The value-based contracting is really between the insurance company and the healthcare provider. And a number of these payment structures on the right, the bundled payment, fee-for-service, value-based payment, a lot of those are ways that the insurance company can pay providers through different structures of fees. Next slide. Next slide. And so we did want to touch on, a lot of our work on the team I'm on, and Brendan is on half-time because he's also spending a lot of his time working on the energy and other side of things, and the rest of the organization is doing a lot of this, is building partnerships. We have energy and health. Both have pretty good cost-saving metrics directly related to dollars. But there's also a lot of these other benefits. When you improve housing, you improve the health of the families who live there, which allows them to go to work and go to school more and increases their ability to make money and get a better education. Those things lead to less likelihood of crime, better societal benefits. And so there's other state agencies or federal agencies or governmental agencies that are interested in those types of outcomes. And so partnering with those types of agencies can help make a joint project a lot more effective. So in New York, we have Attorney General funds in Buffalo around Justice Department issues. And we also we've seen that in Rhode Island, $697,000. And then in Baltimore, and Maryland, we have a number of different combined efforts there as well. And with that, I'll turn it back to Catherine.
Great, thanks so much, Will. So I wanted to cover a few things for preparation for engagement of healthcare partners before we get into questions. And so we'll talk for another 5 or so minutes on preparation for engagement, and then we'll open it up for question and answer for the last 5 to 10 minutes of our session today. Just again, wanted to talk about a few things to consider to prepare to engage these various healthcare partners, whether it be hospitals, Medicaid offices, health insurance providers that are managed care providers, or any other kind of public health entities that may be potential partners for you. So just running through this list that you see on the screen, you'll want to think about the population being served and multifamily properties. What are some of their common health conditions that are impacted by their environment? Are there particular issues that are prevalent in the population that you're serving that would be considered a public health issue that can be solved with application of healthcare funds for home modifications? So that may take some research on your part, data collection, or looking into public health data, surveillance data within your state or county or service area, because the public health providers are going to want to get an understanding of the evidence base for the prevalence of the issue, and then also you may be in need of some resources to define non-energy benefits in this application, which is why we want to share some of our previous research with you, but want to make sure that you have the resources that you need to connect the flow of ideas for your discussion of how you can solve a public health issue, but also that you will be able to see a return on investment for the application of healthcare funds in this context. So that will definitely take some evidence and data collection, thinking through how you will be able to collect data throughout the healthcare process. Again, as we talked about earlier, that may also involve getting some service providers certified and make sure that you've got ways to reimburse for home environmental assessments, resident education, and data collection professionals, and all of the things that we've talked about in the session today, and are happy to get into more specifics through follow-up conversations about what some of those positions may be in the workforce within your state that you're working in. So also think about capacity and scaling. And a lot of the examples that we have provided today, there have been ways to test out some of these funding mechanisms through pilot projects that involve one multifamily property. And some of them are statewide. So it just depends on what the capacity of your partnership may be. Also may depend on the size of the hospital system that you're working with, and other factors. So that's something to consider as you're planning. Also, how you're documenting out services, how you're coordinating that continuum of care in the cases where you're involving multiple players, from assessors to healthcare providers to contractors working and actually doing the applications and so on. So there's workflow to think about in terms of the way that you're setting up these partnerships within a pilot or within a payment mechanism for reimbursements. And again, just looking for ways to collect information to build the business case and the return on investment evidence for the work that you're doing. And in some of the examples of healthcare financing that we've talked about, some of that will need to be presented on the front end of the work, before you are able to secure financing. Other examples that we've provided, you may be able to get resources that will help you build variables in these different payment models, but that we've given you some things to think about and examples of working partnerships with the health and energy sectors to build up some ideas to use within your EFA collaborations or new hub networks within the states you're working in. So I know we've got a couple of questions to get to. I just want to point out real quickly that we have an exercise for mapping next steps if you're interested in healthcare payer engagement. There's a handout that's included in the presentation that will take you through the step-by-step process for thinking out the feasibility of accessing healthcare financing. It'll ask you some questions about what your current home modification financing resources are, what you think some public health priorities are that would be something that would be prevalent in the population that you're serving through housing, and then some of the potential healthcare partners in your area that you could potentially engage. So if you want to take some time to use that handout and try to think through some of those potential ideas for opportunities to engage, help with that. And if you're planning on attending the new HAB convening in Detroit, you can email me ahead of time. Let me know if you want some assistance in looking at developing out answers to that exercise or reviewing your progress. And we'd love to schedule a time to meet over breakfast or lunch at New HAB to work as a group with anyone who's interested in trying to think through some of these partnership opportunities. And with that, we've got about 9 minutes left to answer some questions. I know we had one for Brendan. I'm going to go back to the slide, Brendan. It was back on when you first started talking about Medicaid financing and the rule change. Just had a question about the terminology on this slide. If there's a particular name for the Medicaid rule change being referenced here, or if that's in reference to a particular CMS publication that you're aware of that stipulates this information on the reimbursement for non-clinical professionals. I'll make sure that I didn't accidentally mute Brendan.
Here,
there you are.
I should be unmuted now. Yeah. So there is a CMS memo that corresponds with that, and I guess we don't have the link here. We can be sure to put that link in with this slide, and that way everyone will have it. And yeah, and it came out a few years ago, and I think it was summer of 2014. But it's a CMS memo basically clarifying the rule change. So it's public
I got it.
Yeah.
Thanks, Brendan. I think we've got a couple of other questions coming in. But one thing for Brendan, just for the audience, do you have any particular recommendations that would apply to our audience who are coming from multiple states if they are trying to assess what some of the public health priorities are in their state that are connected to environmental home health? What are some common data sources, public health information that would be accessible to them that they can look for? Should they be looking to engage people from public health data surveillance resources, from insurance companies? Should they be looking at their existing community health needs assessments? What are some examples of places they can go to look for some of those public health priorities?
Yeah, and I'll start, and Will, you can add on. But yeah, I think you named a couple of them. Like, you should look at your community health needs assessment. Sometimes these will be done by larger hospital systems by themselves. Sometimes if they're smaller hospitals, they might partner up with other, like kind of geographical, close hospitals. I'll say one thing, for states, a lot of states have kind of pay for performance incentives or quality improvement, what do they call them? Quality improvement performance plans, or QIPs. And so these are actual financial incentives to the managed care organizations. And so these will be, a lot of times they're quite large incentives. If you fall out of, if you're not hitting the benchmarks, you get penalized if you kind of come in between, you don't get anything, and then if you exceed the benchmark of that standard, there could be large incentive payments. So you can look at the most states for each managed care organization, or sometimes they put them collectively depending on the state, will have a quality report each year to show how they're doing on those different measures. Not all states are those measures tied to financial incentives, so probably have less negotiating ability if there's not direct financial incentives saying, oh well, if we change this and we can improve your outcome here, that they're going to be able to get more financial rewards. So there's those, as well as being able to. An important thing is to be able to build the business case for whatever intervention that you're proposing. If it's around, we've a lot of our Pace for Success work's been around asthma, but injuries and falls, supportive housing, like all of these, like they have measurable outcomes. So a lot of the movement in the healthcare system is really to aligning those to outcomes-based payments. And some certain states like New York and Texas and other large states are mandating that these managed care organizations have a certain percentage of their I think it's 80% in New York, of their contracts aligned based on these kind of performance or outcomes-based, value-based purchasing contracts. So there's kind of multiple incentives, and it depends on the state. So try to find, obviously, the business case for cost savings anytime by reducing hospitalizations or unnecessary emergency visits is strong if you can make that point for any health plan. And my last comment will be, I guess, that definitely we showed a number of different kind of funding options in the toolbox, but some of those, like the waivers, are long processes. So like I was giving Oregon as an example, they just passed the waiver for 5 years. So if you're looking to make changes in the waiver, you're kind of more of a long-term planning. A lot of what we do is try to negotiate directly with the health plans, because they have a lot more flexibility to make contracts with service providers, either being value-based purchasing, pay for success, regular fee for service, or even bundled payments. But the system is made to the path's a little shorter if you're directly negotiating with the health plans. You obviously always need to get approval from the state, so that's important as well. And Will, did you want to add anything to that, to what I said?
I think you covered it. The only two things I would note is you can look up on your state's Medicaid agency, look at they often have PowerPoints or other documents to describe the new incentive structures for the insurers. So that's one resource to pretend you're the insurer. And the other is just a reminder that the State Department of Health and the state Medicaid divisions are not necessarily, and often do not have the same goals or projects. So to think of them as two separate things, even though they're both dealing with health.
Well, that is an important point to make. I know in my state, they don't really interact very often, certainly not as much as you would think that they do. So it's important to make connections in both places and try to find opportunities to bring those agencies together along with your energy partners. All right, I think we have answered all the questions from the audience, and we're about out of time. So we just want to wrap up by saying thank you for joining us. We look forward to continuing this conversation at the new hub convening. In the meantime, please feel free to reach out to anyone from our staff if we can assist you with any of the resources that we discussed today. And we will again follow up by email to share the link to the recording for today's session, the handouts that we included, as well as the other Medicaid rules and paper links that we mentioned in the course of the presentation today. So thanks again for joining us, and we hope you have a great week. Thanks.